Sandy Collier, and welcome to our T. Leroy Jefferson Medical Society Opioid Prevention Program 2025. According to the CDC, U.S. overdose deaths decreased almost 27% in 2024. Right here in Florida, in recent years, drug overdose deaths have begun to decline. Total drug-related deaths decreased by 7%, and opioid-related deaths decreased by 11% compared to 2022. And that's according to the Florida Medical Examiner Commission's Drug Identified and Deceased Persons Annual Report. Now, while we are seeing improvements in opioid-related deaths, there is still much work that needs to be done. And doctors say continued education is key. We'll talk about opioid misuse and misconceptions. We'll talk about the myths about opioid addiction. We'll also talk about responsible prescribing, pain management, and a whole lot more. But first, a message from one of our founding members.
Hello, my name is Dr. Monica Walker. I practice family medicine. I am also the membership chair and a board member of this great organization, T. Leroy Jefferson Medical Society. The Medical Society was initially founded in 1940, and in the 1990s, Dr. Catherine Lowe, Dr. Lewis Anderson, Dr. Virgil Norris, and myself reestablished the organization here in Palm Beach County. Our organization takes pride in leading the way on subject matters which affect our community, one of which is the opioid epidemic. We are in our 5th year of our opioid prevention education program. And our goal for this year is to continue to draw awareness, educate our community, and help in the prevention of opioid dependency and death.
I'm Sandy Collier, and welcome back. Programs like the Opioid Prevention Education Program requires a lot of funding. And I'm so happy to sit here with the Executive Director of T. Leroy Jefferson Medical Society, Laurel Dalton. Laurel, thank you so much. And I want to personally thank you for all the work that you and your team, put into the society. Let's talk a little bit about the society and why is it so important for programs like this?
Thank you, Sandy. Our focus and our mission is improving health and wellness and access to care in the community for those in need in Palm Beach County. The reason that we do programming like this is to improve our physicians. And so you can be practicing for 40 years, but you still have to stay current. And so programs like opioid prevention, it helps them with prescribing practices, and it also helps connect people to care.
Tell us a little bit about, and this picture here, you and I were talking about it, our namesake, Dr. T. Leroy Jefferson. Tell us a little bit about him so our audience can understand exactly who he is and why he plays such an important role in where we are today.
Right, so Dr. Thomas Leroy Jefferson, he was known as the bicycle doctor, and he conducted his rounds in Palm Beach County on a bicycle.
Wow.
He was the first black physician in Palm Beach County, and he bartered for his services, and he often provided them for free.
For people in this community?
That's right, for people of color.
Wow, wonderful. So, Laurel, the society, you rely on a lot of grants, okay?
Yes.
You do an enormous amount of grant writing. Why are grants so important to the work that you guys do here in the society?
Grants are important because they are the lifeblood of nonprofits. They make up to a third of the net assets of an organization. I spend the majority of my time seeking funds for the organization so we can put on the programs in the community.
So why don't you talk to us a little bit about those programs, what they are?
Sure, absolutely. So we have two focuses. One is health and wellness, and that looks like health fairs and trying to connect people and make sure that they have a primary care physician. We have a Moms with Monitors program where we give out blood pressure monitors to moms of color because of the maternal fetal death rate. The other side of that looks like youth development, and so that is college readiness training, mentoring, scholarships, that kind of thing. So, and then we put our doctors to work and we connect them with children and we try to help them pursue healthcare careers.
When students think about the field of medicine, a lot of them automatically think about, oh, well, that means being a doctor. But that's not the case, right?
I'm glad you asked that question. In fact, one thing that I will bring up is T. Leroy Jefferson Medical Society is not just made up of physicians. We have nurses, we have techs, we have people in all aspects of healthcare. And the reason for that is because we have so many programs in the community, we need all hands on deck. One of the requirements for us being part of the National Medical Association is that we have a certain percentage that are physicians, so the majority are physicians. But we pull from all these different specialties and branches of medicine. One thing, when I was growing up, I only saw nurses in my family, so I wanted to be a nurse because that's what I was exposed to. So if you expose children to a technician, different facets of medicine, they know that that's an option for them, right? And it doesn't just have to be a physician. There's all types of careers with and without a stethoscope.
That's wonderful, and hopefully we're getting the message through the kids. I think we are. Laurel, I'm going to give you an opportunity to everyone who's listening, how can people help? How can the community help T. Leroy Jefferson Medical Society to continue the important work that's being done in this community?
Well, as I said, contributions and grants, that kind of funding are the lifeblood of nonprofits, so we can keep going. The way that people can reach out to us is to visit our website, tljms.org, and then go to our donation page. Once you go there, you can put in whatever amount you want, and any amount, big or small, makes an impact. And that helps us deliver services, much needed services in the community.
Laurel, the Health Council of Southeast Florida played a very pivotal role in funding for this programming. Can you talk a little bit more about that? And I'm sure you have something that you want to say to them.
Right. I want to send a special shout out, a thank you to Health Council of Southeast Florida, because we've been doing this programming for 5 years, and that was thanks to grants from Health Council of Southeast Florida. Thank you, and without you, we are not able to service the community.
Laurel, thank you so much to you, Sadia, and the rest of the team, and all the doctors at T. Leroy Jefferson Medical Society. Thank you for all the work that you do in this community, and those out there, we hope that they send in some donations for us.
Up next, I have a candid conversation with Dr. Laura Quinton of APC Pharmaceutical. She has some good news for us in terms of opioid deaths, but she says there's still more work that needs to be done.
I have Dr. Laura Quinton here with me from APC Pharmaceutical. And Dr. Quinton, it has been a while, but thank you so much for joining us. We have some good news, though, right?
Yes.
Opioid deaths are down?
Down.
Showing a decline?
Florida, yes.
Okay, let's talk about that.
Okay. Yeah, perfect. So opioid deaths after COVID have declined. I think it's a lot to do with us being able to come together as a community again and get back out there and just really help the public with the education and harm reduction strategies. And we've seen a big decrease.
But there is still a lot of work to be done, right?
Of course,
so let's jump right into it. As a pharmacist, you're uniquely positioned at the intersection of prescribing and patient care. Could you elaborate on the evolving role of the pharmacist in mitigating the opioid crisis, particularly in collaborative practice mode?
Yes. So pharmacists, for the most part, can offer a lot of education to the public and to the prescribing clinician. So we do a lot of education. I particularly, if we're going to give the medication to a client, we can be the first line to give all the education on what they could expect, what could happen. It's really important to tell your patient everything about that med, even the ugly, to prevent them from going down the road that they wouldn't have chosen to be on. And then also to inform the prescriber, to let them know as well, and let them know there's other things outside of opioids as well. And if they do have to give an opioid, how can we do it in a safer way and prevent further deaths?
So you've got a lot of expertise and in your field. What specific gaps in current healthcare professional education or interprofessional collaboration do you believe contribute most significantly to opioid-related challenges? And we have a lot of challenges, right?
Yeah. We do. I would say, though, really it all comes down to education. If you can get in and you can educate on every single aspect of that drug, and the statistics in the community is a big deal. If you can kind of go in and say, this is what our screenshot of the community looks like in our area. This is what your patient population is experiencing, and target the prescribers on that. It's really helpful for them to say, oh, okay, so we can do something a little different. What do you suggest? And then from there, I could say, let's try a med that's a non-opioid for now. Let's try something as simple as exercise, if that's simple in some people's mind. So I can give them a lot of options outside where maybe they just are very busy and think, what do I do?
Are they receptive? Talk about that.
They're receptive, absolutely. I mean, I think I've built a community of them. So now that they know me, and if I'm a pharmacist and they can kind of trust what I'm going to say, they're receptive to it. I would say the biggest barrier is time. They're very busy, but yeah.
So let's talk about deconstructing opioid misconceptions, okay, from a clinical perspective, okay? From a pharmaceutical standpoint, what are the key differences between physical dependence and opioid use disorder, and how can healthcare professionals effectively communicate the distinction, okay, to patients and families in order to reduce the stigma? Because we have a lot of stigma around opioids.
So to recognize, dependence is likely to happen to anybody on an opioid. So dependence is just your body's physical reaction to the drug. And you're most likely going to experience a withdrawal when you stop that drug. Opioid use disorder is an evolved form of dependence, so it's going to include physical dependence. It's also going to include chemical changes in the brain, memory immersion to that drug, so now everything you're doing is an addiction in a sense of, if you went to the grocery store on an opioid and you're now addicted, like every grocery shopping is immersed in your memory along with an opioid. Behaviors, as far as you can't really do anything but preoccupy yourself with that drug. It kind of shadows everything you're doing in the day. So if a family starts to notice you're not doing anything without first prioritizing that drug, then maybe that's a sign of opioid use disorder. So same for prescribers, that they can play a good part in saying, what my job is to treat your condition, and if an opioid is the way to treat that, then now my job is to monitor you for that and say, am I just looking at dependence? This is pretty normal, it's going to happen to most people, or now we're starting to get into a different world to where this is going to take over and become an addiction.
When do you notice that, though? Or when does...
Well, I mean, if you're on your own, it's probably more difficult. But I would say you're going to have, before you start to notice yourself an addiction, it's going to be friends and family that may say, like, hey, something seems a little off. You're a little more preoccupied in this situation than you usually were before. Or we also don't really see you trying to get to a point where you don't need this, because this, in theory, there's people that need chronic opioids, sure, but really we would love to just treat the issue and be done with it. Yeah.
So beyond the initial prescription, what are the most prevalent myths about healthcare providers, among healthcare providers actually, themselves, regarding the efficiency and the long-term risk of opioid therapy for chronic non-cancer pain?
Mm-hmm. So there could be a theory that everybody would develop an addiction. So maybe there's a fear of prescribing opioids, even if they are warranted in the situation. You could also think maybe certain people have biases to think certain races would get addicted to drugs, certain age groups would be more prone to get addicted to these drugs, but that's certainly not true, because if you look, it's really everybody that has the susceptibility to become actually addicted to an opioid. So just informing, like I said, the prescribers of community statistics and saying, these are your race groups, these are your age groups, everybody and anybody is affected. You see stories of like 2 pilots living on Mayberry Street that overdosed in their car, and you would think, oh, the pilot that flies me to Hawaii would be addicted. No way, right? So it just could be a a thought in their head of who may be more likely to become addicted, and that's completely false.
So talking about biases, okay, how do societal biases and implicit bias within the healthcare settings perpetuate misconceptions about who is susceptible to opioid use disorder, and what strategies can clinicians employ? What can they do to kind of combat this issue?
A lot of self-reflection, for one. You could say in your own head, in your own mind, as a prescriber. We're all human, prescribers or not. If somebody comes in, let's say, to the emergency room, and it is a situation that looks like an overdose of some sort, or even like a misuse of alcohol, your own thoughts to think like, of course, and think a derogatory statement to say. Maybe they're less classy than another person coming in for a different reason in the ER. So, the internal bias of saying, I have a drug user versus somebody coming in with pneumonia, to stop yourself and say they're both disorders that I must treat. So I think that, that's a big deal. Just cut out the derogatory comments, cut out the stigma of if you're a drug user, you can't fully form into a civilized part of society one day with the correct support.
But I'm sure that there are drug seekers that go to doctors, right? How do doctors handle that without stigmatizing or without bias? How do you, if you know that's how does that work?
So if you have there are drug seekers, of course. And if you have a drug seeker, you just have to treat them knowing that. I mean, if you're the sober one, it's the responsibility lies on you to recognize the need for help. So it's going to really lie on you, and hopefully you're educated in the senses of harm reduction and opioid use disorder in itself to say, what can I do to at least give you resources, child, grown adult, whatever it may be presenting to you. What are the resources I can give you to give you a shot at becoming somebody that could walk in here and not have this issue 5 years from now. So self-education, education, self-discipline to not be biased, to not be...
And direct conversations, right?
Direct conversation, yeah.
Honest conversations with the patient. So that brings us to optimizing responsible prescribing and dispensing practice, practical and systemic, okay? From your perspective, at the point of dispensing, what are the most critical red flags, okay, or patterns that a pharmacist identify that warrant a deeper dive into a patient's opioid prescription history or communication with the prescriber? And I know that's loaded, but that's kind of what we were just talking about just now, right? So what else can you add to that?
So we could look for, are these people coming in early all the time for refills? Are they preoccupied with I need a refill sooner? That's going to trigger you to think why, and how are you misusing the drug, because you should have enough to last you a certain amount of time. Multiple doctors, we utilize the PDMP, which is the Florida E-Force. So as a pharmacist or a prescriber, you can go into this database and you can see who's prescribing drugs to a specific patient, what they're prescribing, if they're getting any other drug in combination with it, and how long. And even now, they're doing non-fatal encounters. So now you're going to be able to start saying, have they had a non-fatal encounter, which means have they had an overdose, but they did not pass away. So you can kind of see all of this data in this database and use that to make an informed decision on this patient. So from the PDMP, if we're looking at it, and they've got multiple doctors, multiple drugs on board, you can kind of say something might be a little wrong here. Maybe I should prompt a call to this physician and see what's going on.
So the non-fatal encounter, was that just added?
Yeah, recently.
Let's talk about that. That's interesting.
Yeah, which is very great because there's not a lot, like if you want to go out into the community and ask some of the major hospitals around, some of them will give you data for that. If it's warranted, you're in a situation to where you're collecting data, presenting for whatever reason. They may give you data on that, and you may be able to say how many non-fatal overdoses do we have, or how many overdoses have came in and they've survived or walked away, or EMS data, how many have they went out to a house call and that person's been fine, police data, whatever it may be. But now, I guess, I don't know exactly how it's going to work, but I'm assuming that information is automatically going to route to the PDMP. So in the PDMP, you've got a section for what drugs they're on, the physician that may be prescribing them, the morphine milliequivalents, which will tell you it's basically how much of a certain, how high of a dose they're getting in relation to other things. And then I guess there's going to be, and I say I guess because I haven't actually fully seen it in action yet, but it's going to be a section that's going to say, has this person had a non-fatal encounter? So you're going to see, have they overdosed before, how many times? I mean, I've known people that have overdosed 16, 17, 20 plus times and they've made it, you know?
Wow.
But it is critical for, I would say the most important reason would be this reason. If you have a patient walk into an emergency room, it is a very busy place. We have a hospital down the road. It's a very, very busy place. You may have shootings, you may have strokes, you may have heart attacks. You have all these situations that warrant immediate attention. And if you think about it, you've got somebody that walks in on an overdose by their choice, which is trying to be destigmatized to say this is also a condition. But let's put your grandmother having a stroke next to this person that's coming in with a self-made choice to overdose. Most of the time, we care, and that emergency department cares, but like we've got a situation over which one's going to get favored. They're both going to be treated, but what's going to be favored? And that's to say you're not always going to get the best data out of these hospitals, because what if they don't even realize it was an overdose? And what if the patient leaves and anything could happen? So you're not getting great data for overdoses. Well, now if you are getting at least that data, we can say, well, how many times have you overdosed? Which then can prompt us as a healthcare professional, doctor, pharmacist, EMS worker, to say, I think you need further help. Let me give you some harm reduction strategies. Let's connect the dots and call other people that may be able to route you to somebody that can actually help you because you got looked over in the ER that you actually went to for an overdose. So now it's just data to trigger us, almost like a social work, to say, I see you. You need help.
Right.
Yeah.
Well, listen, that went right into this next question I was going to ask you,
Yeah.
okay? Could you discuss specific strategies for effective interpersonal communication between pharmacists and prescribers regarding high-risk opioid prescriptions, particularly when there are concerns about diversion or problematic use? You just talked about that. So what else do you think needs to, what else can be done in terms of that?
I think a very good open communication situation with prescriber and patient, and really treating them as a whole to look for those signs to say, are we where we need to be, or are you starting to kind of get out of hand, and how do we reel that back? Also educating the prescribers on the PDNP to say you can use this to see, are you their only prescriber? Have they had any overdoses, stuff you don't know? Because there's honesty in PDNP, the E-Force. Not to say that these patients are liars or dishonest, but that's an embarrassing situation to say, well, I overdosed twice last week. So honesty in PDMP is going to be an effective thing. But I doubt even on this series, there's going to be some prescribers that are going to say, wow, you can see overdose data now, like non-fatal. You can see that. That's great. I want to know, just to help better my patient.
So it's more tools.
Yeah, a lot of things they don't know. Now they can see.
That's wonderful. Yeah. So beyond legal mandates, what are the practical benefits and challenges for healthcare professionals in fully utilizing prescription drug monitoring programs, which we just talked about, to inform safe opioid prescribing and dispensing decisions?
So like I said, there's honesty in the PDMP. So it's going to tell you the truth. It's mandated to report that. So any doctor that is going to see the same patient is going to report any opioids that they're prescribing. Well, it's going to come from dispensing data in the pharmacy. So that's going to be reported. Then, like we said, overdoses now are going to be reported. The past, I think the PDMP goes back 2 years. So you're going to see 2 years of past drug history, prescription drug history. So there's just a lot of tools that you can see just by taking the few seconds to pull up that PDMP and see what you're prescribing your patient and if it's the best choice for them. And that's a lot of pharmacists. I mean, we're very good at saying, let's educate you on this, because there's a lot of prescribers that don't even realize they're supposed to be on the PDMP. It's actually a legal mandate, but they don't know. They should be on it. So we tell them, they're like, oh, okay. And they can just delegate somebody to check it every time they have a new patient before they start them on any kind of narcotic therapy at all.
So is it a check for every single patient, or how does it work? Do they, if I go into the doctor and go into the pharmacy and I give a prescription, do they check right away? How does that work?
If it's a control, they're supposed to check. Yeah. If you're getting a controlled substance, they're going to check the PDMP and make sure you're not getting that from several people, and you're not getting several controlled substances all at once. And how often are you getting them? So it's a safety thing.
It's good.
Yeah, it is.
So I guess and a lot of that is probably contributing to some of the decline, would you say? Or
yeah, I would think now that there's a lot of accountability for it and we can see what's going on. Even as far as like prescribing and dispensing, there's a lot less willingness to prescribe and dispense, which in itself could be a problem in some situations, than there used to be. So yeah, I would say it helps with the decline.
So sometimes you have to put people on long-term opioids, right? So how can pharmacists proactively counsel prescribers on appropriate opioid tapering protocols and the management of withdrawal symptoms in patients discontinuing long-term opioid therapy? Because I think that's a lot of the concerns too, right?
Yeah, how to get them off. Yeah.
Yes.
Because like we said, you can most people are going to get dependent. And when you get dependent, that's not going to be fun to come off of an opioid. So a pharmacist's role in that would be, like, we can always collaborate with the physician to say, what are you prescribing? How can we taper it down? Mm-hmm. So if they don't have a lot of time or like the knowledge to figure out how to taper that down, there's really no reason as pharmacists in that realm that can't say, let me write, give me the patient, let me tailor something to you that says this would probably wean them down without just putting them into full withdrawal. And also recommendations for withdrawal symptoms out of those patients. I mean, a lot of them are going to be very sick. Withdrawal's not fun. It's very sick, nauseous, restless legs, racing thoughts, anxiety, all of these things. So are there things, I know I'm a pharmacist, but like less drugs is more, the less you need. So what do they actually need? What's something that would treat a real symptom? Do they have such anxiety that's going to send them somewhere? Let's give them something to calm them down. But there's so many drugs for anxiety. What's the best choice for you? So I think for us, that's what we can do for a physician, is really help them get those symptoms into a realm of meds that makes sense.
I think we may have time for like one more question here, okay?
Yeah.
Time sure flies when we're having fun, right? 'Cause there's just so much to talk about, and it's very interesting. So what role do pharmacists play in implementing and monitoring opioid stewardship programs within the healthcare system or community settings? Okay, and what metrics most useful for evaluating their effectiveness?
Okay. So, in a lot of hospitals, I will say, and I have over a lot of mental hospitals. So we play a big role in like the policies and procedures. So let's say that there's a lot of policies concerning opioids or, whatever. We can go through those and make sure that they make sense. So we have a big role in that in collaboration with prescribers and administration. We also, as pharmacists, we are approving these drugs. So they're going to first go through a prescriber. They're second going to go through a pharmacist. If we happen to see anything that we think doesn't make sense or could be optimized, that's a great place for us to step in and give our recommendations if they're accepted or not. And then outside of that, and specifically at my hospitals, we have drug utilization sheets where every single opioid that comes through for a patient, we actually log it into a sheet. And it's what's the drug, what's it being used for, is it FDA approved? Is the patient experiencing side effects, sedation, anything like this? And has the prescriber reviewed that opioid use within 48 hours? So all these questions for one drug get logged in. So we are, as far as metrics in pharmacy, and this is really hospital-wide that I've seen, we are looking at opioid usage, if it's being used correctly, and if that drug really pertains to that condition that it's being written for, and it's not just part of something that they say, I give this to everybody for any condition. So yeah, I would say as far as opioid stewardship, pharmacists are very involved.
Wonderful. So we're seeing a lot of improvements.
Yeah.
We're seeing declines. Okay, so all around things are, well, they're getting better, but we have a lot more work that still needs to be done.
Yeah, and probably the best bet is to get out. I personally love Rebel Recovery, and I love them specifically. I'm not affiliated with them, but I love them specifically from what I've seen them do, because I think the best way to start moving this forward as well is everybody be on the same page, but also the people that are actually using and are the community of users. Those are the people that know the best. They know the best. If we get in there and really talk to these people and say, what are you experiencing? What does this look like? Your party you were at the other day, what do things really look like? And then from there, that's what we're educating. So we're educating the prescribers on the real world, and then we're taking that back to the real world. It's just, communication makes the best relationships, right?
Dr. Quintin, we always have a wonderful conversation, and I want to say thank you so much, and thank you for all the work that you're doing in the community. And come back and see us again, because I'm sure there's a lot more as we see more and more overdose death decline, which we're hoping for, till we get it down to 0.
Yeah.
That would be great, right?
Great.
Thank you so much for joining us.
Up next, I go behind the scenes at Bridge Care Pharmacy in Boca Raton with Dr. Jatos Atenir. She explains the dangers of opioids if they're not prescribed properly. Dr. Jatos, thank you so much for inviting us here into your space. Now, this is Bridge Care Pharmacy, right?
Yes, it is.
Tell us a little bit about you, yourself, and this beautiful facility you have here.
Sure. First, Sandy, thank you so much. It's a pleasure having you here. My name is Jatos Altine, or Dr. Jatos Altine, as you said. Bridge Care Pharmacy, we really think of it as more for the community. It's a clinic and a pharmacy at the same time. We get to see patients if they walk in. We have our nurse practitioners on board, and we get to dispense the medication to them as well. Myself, I've been a pharmacist for about 21 years. I don't want to date myself. But it's been a while. I graduated from Nova Southeastern University. I completed a general pharmacy practice residency at Jackson Memorial in Miami and have been at it since then. So here we are right now trying to fulfill a dream of our own spot.
This is actually amazing. I was doing a tour, and of course we'll talk a little bit about that a little bit later on. But from from the opioid perspective, you as a pharmacist, you're on the front line. So let's talk a little bit about the role the pharmacists play in the opioid crisis.
Really, when you think of the opioid crisis, this is a nationwide epidemic. It's not a Florida thing. It's an everywhere thing. It encompasses generations, it encompasses race. It really doesn't matter who you are, you can fall victim to the opioid epidemic. But what we see as pharmacists, our role in the front line as the person who's most likely the one to get to talk to the patient for the first time when they're seeking a controlled substance, we see ourselves as educating patients and reducing harm. We work with the providers, we become a team, we collaborate, not just pharmacists, but physicians and physical therapists. We work together to make sure that the patient has an idea of what's going on when they get to receive that prescription, that controlled substance prescription.
So talking about that, from your perspective, at the point of dispensing, what are the most critical red flags or patterns that pharmacists identify that warrant a deeper dive into a patient's opioid prescription history or communication with the prescriber?
Now, we look out for many things as a pharmacist.
Let's talk about those things.
But so first, I would say, like I mentioned, this is an epidemic, and this is something that, as pharmacists, we're on the lookout for. Some of the red flags that are critical that we look for are, for example, what's a red flag? A red flag is something that causes us to pause. We say, okay, I need to take another look at this before I dispense to the patient. So some red flags: unusual patient behavior. Patient comes in, maybe a bit too friendly, a bit too loving, and brings in some cake or some candy, or patient's a bit too aggressive or a bit too in your face, I would say, and patients who have insurance, but they don't want to use their insurance for controlled substance, or they can't afford insurance, but they want to pay with large sums of cash. Or patients, if they're doctor shopping or they're pharmacy hopping. So basically, they come in with a prescription from multiple prescribers, or they have one prescriber they use for multiple prescriptions of controlled substances. You have patients, they a little bit too familiar with the terms in the streets, like the street names of you have patients come in and say, hey, I want my oxys, or can I get my Xanny bars today, or can I get the ones with the stop signs, or the dents. So that gives you a minute, hey, this is your first time getting a controlled substance, but yet you know all the
Wow.
you know a little bit
All
too
the
much.
terminology.
The terminologies, yes. We look out for patients' addresses, patients who live too far from here, or the prescribers are too far, or so it tells you the patients maybe, just maybe, might be going around from pharmacy to pharmacy. So there's a lot we look out for. Also, there are some known controlled substances that are that we know for sure that we need to be careful with. For example, oxycodone, prazolam, carisoprodol, that in the pharmacy world, we call that the Holy Trinity. So it's like, wait a minute, we have the Trinity, hydromorphone, alprazolam, carisoprodol. So we know that at a point, if we see any of these, we pause and reach out to the prescriber and see what's going on there and get a clearer picture.
Why would a doctor prescribe a Trinity, the Trinity? Can you talk a little bit about that?
Well, we want to stay away from that. And any doctor really would know this is something that would put the patient at risk. So we steer clear from that.
Okay.
Yeah.
But do doctors prescribe that? Like
You
in
would
terms
you
of
would see
like
it.
what kind of pain?
Well,
would that be like cancers or?
It could be cancer, but like I said, the Trinity would be something like oxycodone or the hydromorphone, yeah, for the pain. But then you have alprazolam. So you have a risk of drug-drug interactions that could put the patient at risk for respiratory depression, for example. So this is a patient you want to really look closely into their profile and see, wait a minute, what else? What are the disease states that I need to look out for? Or is that really necessary? Or any other steps that I could recommend to the doctor to say, hey, maybe we should do something a little different here. And these together will not be okay for the patient.
Wow. So I think that goes right into the next question, and we're going to talk about what are some key elements of an effective harm reduction strategy for a pharmacy, from a pharmacy perspective beyond just naloxone dispensing?
Well, one big step we've taken in the regulations recently when it comes to the crisis is allowing pharmacies and pharmacists to dispense naloxone based on a patient-specific prescription or just a standing order. So if we have a patient in an emergency, yes, pharmacists would have a naloxone with them, and there would not be an issue to say, hey, I can help this patient. So with naloxone, not just expanding access to it, we can also educate family members. We educate other people around them to know exactly what to look out for when it comes to opioid overdose. What are the signs? And teach them not just to know the signs, but what to do when it comes to an emergency for opioid use. So at that point, the patient really would have family support or someone around them who knows what to do, how to administer the naloxone, and how to stay with them and call for help and look out for the signs.
Okay. So, Doctor, beyond the legal mandates, what are the practical benefits and challenges for healthcare professionals in fully utilizing the prescription drug monitoring programs, also known as PDMPs?
Yes.
Okay, to inform safe opioid prescribing and dispensing decisions?
Well, PDMPs, I would say thank goodness for them, because it wasn't too long ago that we didn't have access to the prescription drug monitoring programs. In that sense, if a patient goes to one of the chain drug stores and they come here, I would not have an idea what they received, when they received it. But now with PDMPs, we get a great overview of the patient's dispensing record and history. We're able to see when they got the last medication, what it was, any interactions, are they at risk for any overdose? Are there patients that can benefit from a counseling session regarding dangers of opioids? We work with the prescribers as in knowing, okay, this might be too soon, or we can hold it for maybe a few days, or depending on the prescriber and the patient's need. So it really gives us a great overview of what's going on with the patient's dispensing records. It also allows the prescribers to be more confident, because now they can see beyond their electronic health records. They can see, okay, this is what they got, this is where they got it, this is the last prescriber they got it from, and they're more comfortable as far as prescribing. And in turn, that helps prescribers not really as cautious as they could be, but they have an educated, they make an informed clinical decision in that patient's case.
So in essence, doctors, pharmacists, everybody working together.
Everyone works together. Now, as far as any challenges to the PDMP, we have to say each state might have a different version of a PDMP. And as far as interstate data sharing, that could be challenging if a patient, again, we're in Florida, so patients come and go from neighboring states or from all over the nation. So it might be difficult to get a good idea what that patient is really on when you're traveling from state to state. So that could be a challenge. And some prescribers express concern about maybe having a more in-depth education regarding how to use and the interpretation of data in the PDMP. And of course, with any system, you have to make sure that the information that's inputted in there is accurate
Right.
and it's timely. So if you have pharmacists, we have to report to the PDMP on a daily basis. So again, accuracy and timeliness, one thing that we look into as well. But benefits for sure.
Overall, it's a good tool.
Absolutely.
There's no national database, right? Sharing?
No, not at the moment. You do have interconnection from state to state, but that's a work in progress.
Okay.
But we're almost there.
So, doctor, what are some evidence-based non-opioid and non-pharmacological strategies for chronic pain management that are often underutilized?
Well, patients sometimes, when we're in pain, we want the best, right? We want it now, and
Exactly.
we just want to feel better. And
Absolutely. I have a very low threshold for pain.
We've all been there. We've all been there. But of course, we would try to, as pharmacists, counsel the patients. Listen, there are other things. You have, for example, NSAIDs, or the what we call the non-steroid or anti-inflammatory drugs like ibuprofen. For moderate to less than moderate pain, we think of naproxen, like Aleve. All these things they're used. And what we do is we talk to the prescribers. Hey, do you think your patient would benefit from this and from that? We have topical analgesics like lidocaine and capsaicin. We even use some antidepressants like amitriptyline, duloxetine. All those can help, especially for nerve pain. We have anticonvulsants like gabapentin. So there are options. And when it comes to non-pharmacological treatments, we think of exercises. Can you benefit from maybe a little low resistance, a little walk, a little swimming? Of course, all according to your prescriber's recommendations. Can you benefit from a massage? Hey, couldn't we all?
Right.
Could you benefit from that? And as far as acupuncture, some patients we recommend Tai Chi, yoga, or just other ways to manage that pain, and that necessarily helps to reduce the exposure to the opioids and maybe stay away from them altogether. So definitely we collaborate with the patient as far as educating them on what's available, what's out there, what physical therapy, qualified professionals out there to be able to help in that case. And we can identify patients on behalf of the prescribers as well and say, hey, maybe this patient could benefit from this, could benefit from that, and work with the prescribers and encourage the patients, of course, just to take an active role into their care and try to manage the pain. And that helps.
Doctor, we have a lot of medical students that are listening to this program. Mm-hmm. And I always like to give you guys an opportunity to talk to the next generation. Mm-hmm. What do you say to them? Those that are planning to be doctors or those that are in school right now? Mm-hmm. What's your advice to them?
To our future generation of physicians, prescribers, practitioners, first, thank you for going into this really rewarding profession. But one thing I have to say, at the end of the day, you're not alone. Pharmacists are your support, and a lot of times we might see each other as competing maybe for the same patients, but at the end of the day, we're here to help each other out. We love to collaborate with our physicians in the community. We love to know that we all have the same goal, and the goal is to take care of that patient to the best of our abilities. So definitely have a pharmacist on your corner. Have a pharmacist you can rely on, you can call, any questions, anything that you have any doubt about. And that's what we do. We're here to help each other out, and we rely on your knowledge, and you can rely on us to make sure that the patient gets the best care that they can get.
Doctor, thank you so much for allowing us to come into your space, and during this workday, thank you for spending the time with us. We've learned so much, and I always like to thank all of you, especially for what you're doing in our community, especially the minority community, helping to educate and train and teach. You guys are doing a great job, and you should be proud.
Thank you.
I'm Sandy Collier, and we'll see you again next time. Hello. Hi, everybody. Thanks for joining us. I was waiting for Dr. Taylor. Hi, everybody. Thank you for joining us this evening. I know you guys had a lot going on, but I'm glad that you all decided to join us. We've got a few questions that came in, and one of the questions that came in was, from a clinical perspective, what policy changes at the institutional or state level would be more impactful in addressing the opioid crisis?
I think that like when one where we do CEs, kind of, which some of these were like, another mandatory CE, but I guess get them where you can, right? So we could make it mandatory that any clinician, provider, pharmacist has to do some kind of CE just on PDMP awareness, because there's so many people that don't realize that you have to use it, or that you should do the register, or even how to use it. I think it would benefit. So that's one place you could start, just so there's a check mark box and a data recording that says, yep, at least we know everybody is aware of it, even if they paid attention or not, because now it's mandatory. You have to take it to keep your license. So, or to renew it. Policy changes in individual sites. Those, every site has their own policy. So I don't know what they all may look like, but example, you would want some policies just to have information about that, where to check PDMP. A lot of hospitals, you don't have to report it. But on some special cases, a lot of hospitals, they have what are called power plans. So that means, let's say you have a surgery or an orthopedic floor, for example, any of that, and it makes sense that a lot of those power plans are going to include an automatic opioid for pain control. But at the same time, what do those policies look like to say, for how long, forever, are we just going to have power plans that automatically include opioids? Because the only places those are kind of checked and maybe questioned for use or pharmacy, when they may see a power plan, it's automatically dropped in. You've got morphine, you've got Tylenol, you've got all these things that could be on there for constipation. You may even have like a cough medicine power that's in that power plan, just because what if? And a lot of power plans are great, but for these type of medications, when they go through pharmacy, that's when we're saying, do they need that one? Or what level of narcotic are we giving them? What kind of surgery do they have? Everybody's pain is different, but like, does it really make sense to have this automatically included in a plan to give to somebody? So stuff like that, to me, in a hospital, doctors are so busy, we don't really have time sometimes to not utilize some power plans. But in the hospitals I see, they are very questionable sometimes, and we are just automatically, even in the ER, you could have somebody come in for a stomach ache, and you could literally see like their encounter for visit, or reason for the visit, and the encounter is stomach hurts, and it'll literally just say stomach hurts, and they are like, you can see, but okay, they were prescribed a morphine and maybe some like sucralfate, and it's like, oh, that's interesting, but like, what? Okay, stomach hurts, all I can see is stomach hurts, and we're giving them morphine. So maybe policies to have a few more steps in opioid prescribing. So changes like that. Outside of that, I don't know. I mean, we're doing better year by year. We're doing a little better with opioids. So
Okay. So another question. What role do you see for telehealth in expanding access to both pain medicine and substance use disorder treatment? And what are its limitations?
okay, yeah, and like I said, the limitations are definitely, some of these conditions shouldn't be just a phone call. Some of them absolutely should be evaluated in person for hands-on. And obviously, limitation of telehealth is you're not really getting that. So but for substance use disorder, I love the idea that you could do telehealth, because a lot of these people, they're not in the right sense to make appointments, to keep appointments. What if they can't drive? What if they have nobody to take them? They just can't get there. So maybe their substance use disorder recovery is hindered by it. They know they can get the drugs, but as far as trying to participate in a program or in appointments that may offer some relief, they just can't get to them. So I do love the idea of telehealth in as a tool for substance use disorder, because at the end of the day, we're hey, we know what you're here for. Maybe you've been somewhere for help, maybe whatever it may be, you've been out to the hospital. It'd be nice if the hospital said, hey, I can refer you to this telehealth management area that can help you with your substance use disorder, and getting some of those scripts like Subutex to be prescribed, and maybe help you at least cut down the cravings, because it could be helpful. I mean, just especially in logistics overall, and
Right, right. And did I hear you correctly? Did you say something about antibiotics, about telehealth?
yeah, just my opinion. I'm saying a lot of people have their opinions about telehealth and where it is utilized, and what should be allowed with telehealth, and that's fine. Just example, like, some people would absolutely hate the idea of pain management via telehealth.
Uh-huh.
But on the flip side, like, we prescribe antibiotics all the time for telehealth, and that, like, I don't love that. So
Okay.
basically there's just differing opinions on areas where telehealth should be appropriate, but to each
Uh-huh.
their own. I just personally, substance use disorder especially, I think telehealth could be a really good tool.
Okay. And why don't you like why not antibiotics? Well,
Well, just, we don't have a lot in the world. There's not a lot of
uh-huh.
antibiotics, and
Okay.
I mean, this is a whole other webinar, Sandy. We can go
Okay.
on it.
Okay. Okay. I got that.
But
So,
no,
so our
but
next
overall,
interview,
I
we're going
just
to
don't.
talk about that.
Yeah,
Okay.
absolutely. But like,
Okay.
taking antibiotics, like, if you go to, hey, my throat hurts, and you just give an antibiotic, where maybe it's just a virus and it's going to do absolutely nothing, but now you're prescribed a Z-Pack. One day those
Okay.
Z-Packs are not going to work, they're not going to work. And then what are we going to do when we have no antibiotics that work against all these germs out in the world? Nothing.
Okay. Yeah. That.
We're going to wish
Okay.
Okay, that's a
Yeah,
that's an
yeah, yeah, yeah,
plus. Okay, so I have
yeah, yeah.
another question here for you because we've only got a little bit more time. So, is there a cost in talking about the power plan that you were talking about? Is there a cost to the patient for the power plan since there's extra work involved?
No, actually, a power plan creates less work. So no, not at all. These are a power plan. All right, so that basically means an order set. So if you go into a hospital, you're getting uh, quote prescribed meds for your stay, but you're not. They're just doctor orders. So sometimes if you're going to get admitted, if you go to the ER and you're going to get admitted for, let's say you had a heart attack, so now you're going to be admitted for a few days. That prescribing physician, instead of going in and putting in an order one by one, which would be insane, you can create order sets. So it would like the click of a button, like maybe you have for a heart attack patient, maybe you have a DVT protocol order set. And so you're just going to click that, the name of that. So maybe a set of orders is called DVT order set. All you have to do is click that and it's going to drop down every single medication that you want in that order set into the queue for pharmacy to review. And those are great, like absolutely great. Otherwise, I mean, doctors are inundated. So can you imagine going actually order by order and hand entering those? No, it'd be insane. But there are certain medications that are allowed to be included in these power plans that they can one button click, which, like I said, is a great thing. But there are certain medications in these power plans that maybe should have a little bit of more evaluation. So, hey, awesome power plan, all these maintenance, comfort meds, whatever you want a power plan, but there are certain medications, like why do we need 4 different narcotics in a power plan that you can just click a button when they may or may not need it, but because the order is sent to pharmacy, unless we have a legitimate question to question it and say, why is this on here? Is there an allergy? Is there whatever the reason may be? Then they're just going to get approved and be on this profile. And then, if the patient says they're in pain for whatever, and they will say, they have to say, like, if it's a pain med, it has to say for pain
Right.
mild, for pain moderate. So, but it's really the discretion, like all the nurse can really say is, well, what level is your pain? Mild, moderate, severe, what is it? And from there, there's usually automatically in a power,
Right.
like
Right.
there's an opioid in there. So I'm just saying, like, why like, let's let them tell us we're in pain and then gauge it and then decide, like, is that an opioid type situation, or should we just be giving them ibuprofen 800, which to me is actually probably the best pain medicine out there. But
Right. Right.
so yeah, I don't love opioids included in power plans, and that's what that means. But power plans are a beautiful thing. Just
Well,
some meds could be
right. Well, thank
a
you
lot.
so
Yeah.
much. Thank you very much, Dr.
Yeah.
Quinton. It's always wonderful to talk to you. And everybody who joined us tonight, thank you so much for taking time out of your busy schedule to be with us. And please have your phone ready at the end to scan your QR code so you can obtain your CME credit. Thank both of you. I'm Dr. Quinton, our panelists, and Dr. Jatos for being here with us. And for more information about opioids, please visit our website, www.tljms.org. And somebody is going to win a gift card, and you must be in the US to win the gift card, and we will let you know who that gift card winner is. Thank you guys again. This is our 5th season. We are very happy, and thank you all for your support. Have a wonderful evening. Again, I'm Sandy Collier, and I'm your host this evening. Good night.
Hi, my name is Dr. Arlene Taylor, family medicine physician and board member of T. Leroy Jefferson Medical Society. On behalf of our organization, we would like to thank you for taking this opportunity to learn. We would also like to thank our dedicated team and panelists for playing a vital role in making this series possible. If you would like more information on the T. Leroy Jefferson Medical Society, please visit our website at www.tljms.org. Thank you again.